talking about gaining a better understanding of trauma. So this is a quote from our foundational curriculum. And so that we can all be solidly grounded in this information, and so that we can build upon this information later on in the presentation, I'm going to read a longer excerpt from that same curriculum. Understanding trauma and how it impacts survivors is pivotal in our ability to support survivors. We call this framework trauma-informed, and it is healing-centered. Trauma-informed practice guides our work. Questions that suggest blame are harmful to survivors. Trauma-informed practice means we ask questions that reflect an understanding of the impact of trauma and honor that survivors are doing the best they can given what they're experiencing. They are strong, capable people who are responding to a traumatic experience, and every trauma survivor's responses are personal, they're very different, and they're all very understandable and normal for them. Critical to understanding trauma and moving into talking about trauma-informed care later on in the presentation is really that we meet folks where they're at, and that we are open to hearing whatever they want to tell us, and also open to understanding that there may be things that they don't want to share with us. A trauma-informed approach centers the survivor and their self-identified needs, which informs support and resources that advocates and others can provide. Listening and following the survivor's lead are critical to offering trauma-informed and healing-centered care. So we would like for you to start thinking now, because you'll have an opportunity later on in the presentation. We'd like you to start thinking right now about how you will incorporate some of this into your work, how you already do incorporate some of this into your work, or how you want to maybe moving forward. So how do you incorporate choice, trust, and maybe affirmation into the work you're currently doing, or how do you want to be doing that? And we also want you to be thinking, as we move along, where are the places where it might feel really difficult or might seem impossible for you to incorporate some of this stuff in your work. So just be thinking about that, and you'll have an opportunity to share a little bit later. When you hear the word trauma, what do you think of? I'd love for you to unmute. You can also share in the chat, and Katie's going to work on collecting your responses, and then she's going to share them in the chat as kind of a list. So when you hear the word trauma, what comes to mind for you? What do you think about? I can give an example of a car accident. When I think of trauma, I might think of a car accident, or I might think of something really bad happening to someone. When you hear the word trauma, what do you think of? And there's no right or wrong answer here. So I see that the chat is active, so that's great. We're getting a few responses, Katie. All right, perfect.
Yeah, we have, actually, I don't even need to do a summary because everyone's in the chat. A life-altering event, devastating experience for someone, lasting and impactful negative experience, residual harm incurred by an event, a terrible experience, an unexpected horrific event in someone's life, affects how people react to future experiences.
That's great. Thank you all for making your own list. He doesn't have to recreate that. So as we all look at those examples together, is there anything you notice or anything that stands out for you about that list that you've created? And again, please feel free to unmute if you'd like to speak. If not, you can respond in the chat. Anything that stands out for you?
I have an observation. In our curriculum, they give us notes, cheat sheets, and they include, what your audience might brainstorm at this point. And what I think is really interesting about this group is that there's a pretty focused a theme of impact in addition to the event. The list we have is mostly about events, examples like Kayce had a car accident, or war, an emergency, or but I think this is a group who understands impact in innately. So I think that's a really interesting theme with this group. And then Matthew Wyman says, all of these speak to a lack of control. Whatever happened to the person was not their fault. That's a great theme as well. Thank you.
Yeah, that's a wonderful place to land right now. And really in line with what Katie was just saying around just us being very knowledgeable about trauma and the impact of trauma. I'm also reminded that when I think of trauma, it's bigger than the abuse or the crime that happened. Like the trauma is bigger than the event itself. And I think about talking with survivors of sexual violence because I've spent most of my professional life talking with survivors of sexual violence, and them sharing with me that they didn't actually come to me to talk about the abuse or the assault that happened to them, but they came to talk about all of the losses that were associated with the abuse or assault that happened to them. And so trauma is really multifaceted, and it's much bigger than the event itself. There are many definitions of trauma. There are clinical definitions, there are holistic definitions, and everything in between. We're going to use this as our definition, our kind of shared definition as we move forward with trauma. So trauma is an experience or experiences that cause overwhelming stress. And trauma is what happens inside of you as a result of traumatic events. It's a loss of connection to oneself and the present moment. Is there anyone here who feels like in their life they've never experienced overwhelming stress? Can't see everyone. I'll try to scroll down. See any icons or thumbs up. So
no one's jumping up and down.
No one's saying me. I've never had overwhelming stress. Yeah. So with this shared definition that we now have, what we can also kind of say is that trauma is incredibly common, if not universal, to all of us in some way, shape, or form. And we know that understanding the impacts of trauma, which you really spoke to in the last kind of little activity, understanding the impacts of trauma allows us to understand the support, the services, and the resources that are available to victims and survivors, which is really, really important. So we know that trauma is the way we experience an event, the way we experience it physically, emotionally, spiritually, socially, relationally. And we also know that there is no one way that people experience something, right? There's no one way. People experience similar things very, very differently. A similar experience can happen to different people. And based on a series of factors related to their lived context, they may experience an event very differently. And this is really normal, right? There's no right or wrong way to experience trauma. Can you think of, in your lives or your work, can you think of kind of examples or situations where, yeah, people have been through like a similar experience, but the impact of that experience on them or their reaction to that experience has been very different? Would anyone care to share?
Kayce, this is Kartika. I think that for me in my environment here within the military, that a situation that might have occurred during deployment could affect different people in different ways. So an incident on a convoy might affect one person, I'm going to put in quotation marks, minimally, and then someone else who is in the same vehicle may experience some significant after effects from the same situation.
Absolutely. I really appreciate that example. Anyone else have an example that they'd like to share? For me, I think about, this is similar to the example that Kartika provided, but I think about a car accident or a plane crash that someone has, whether that's in military service or civilian life, and everyone involved in that's going to experience it very differently. I also think about my work with families and siblings and family systems over the years. And I think about supporting two siblings, very close in age, grew up in the same family. There was intrafamilial sexual abuse going on in the family. And those two siblings have a very different lens of their childhood and their experiences. So yeah, there are so many examples of how we experience trauma differently, even if we experience something very, very similar, maybe to the outside world, almost exactly the same as one another. All right, thank you. We're gonna move on a little bit.
So this is going to be our first opportunity for breakout groups, for you to look at each other's faces and chat for a minute. We want to take the event, the traumatic event, the two-dimensional traumatic event, and try and make it more of a sphere to better understand how a traumatic event might impact someone's life. And again, this is all in the interest of affirming and supporting the person in front of you, right? And understanding where they're at and where they might be coming from and all the different variables that might be impacting their behavior, their needs, and their own perspective of their experience. So we're going to put you into 3 groups. For those of you who haven't been to great breakout rooms before, when we send you away, it's going to give you an invite to go to a room, and then you click on it and you'll be sent to a group for just 5 minutes. And then when the 5 minutes up, we'll bring you back. We have the power to transport you back. So I would ask that someone take some notes and be prepared to share. We're just going to take 5 minutes. Each group is going to answer 1 question. So Kara sent out handouts before this training. This is one of the handouts. If you like having handouts open and referencing documents, you could open that up right now. It is the one called factors that influence trauma worksheet. Oop, there we are. So we're going to send you away, pick someone to write, someone to share out. And group one is going to think about the individual factors that are specific to each person prior to a person's experience with abuse and violence. What are individual factors? So what are individual factors, personal factors that impact someone's experience of a traumatic event? The second group, event factors, how the event took place. What factors describe circumstance of abuse or violence? What are some event factors that might impact how someone experiences a traumatic event? And then the third group is going to think about environmental factors or cultural factors or place and time that might impact how someone experiences a traumatic event. What are some environmental factors? And as you're thinking, we want you to think about a traumatic event that is likely to be in your sphere, to be in our world, which is interpersonal or something that would be within the criminal justice system. I think it's really important to look at and think about traumatic events in our lives that aren't interpersonal, that aren't violence, but I think we're going to focus on that today. So again, group one, you're going to think about individual factors and report back. Group two is going to think about the event factors and report back. And group three are going to think about environmental factors and report back. I will also put in the notes in the breakout room, you'll see above at the top some cues for that. Any questions? Do you have enough instructions? Okay. I'm going to send you away for 5 minutes. Random groups. All right. See you in a bit. Okay, so let's debrief. Let's share. Which was the first group? Who would like to share what you talked about in regards to personal, individual things that impact how we experience a traumatic event? What lucky person gets to share out?
I think Courtney should do it for our group.
Hey, voluntold. Courtney, would you like to share?
I said her name, but mine Mike was muted, so that's
Oh, too late. Not fast enough.
shoot.
Right.
I didn't
Go
know
right ahead.
muted.
We'll help.
So we talked about a couple different aspects, whether it's financial, family, substance abuse, or mental health. For the financial aspect, say you have a domestic violence victim. So do they have the funds to leave right now? If they're going to leave, are they leaving with their kiddos? And if they are, do they have enough funds set aside where they can move their kiddos into an apartment big enough for all of them? Or if it isn't an apartment, where are they going? And just, can they survive on their own? Do they have their own job, or is the money tied up somewhere else? And that goes into the family aspect as well. Around the holidays especially, that gets hard, because if you have kiddos again, are you going to disrupt the typical family holidays by leaving, or are you going to stick through it and just deal with the abuse that's going on because you're trying to keep as much normalcy as possible? And that also ties in, substance abuse. If someone is around something, abusive, and it's easier to self-medicate to deal with it, and then you become, that becomes a habit, and then trying to break that habit. And do you have insurance to cover the counseling for that? Or how do you move on from substances, and do you have those family supports in place to help? Because going through withdrawals is not easy, and you need someone to lean on. And then mental health counseling, because or mental health issues, once you've been in some sort of abusive relationship, whether it's child abuse or physical adult abuse, whatever it is, there's this trauma that we're here to talk about today that's lingering, and it's going to affect all relationships that you have. Those flashbacks do come, and it's dealing with those flashbacks and learning the coping mechanisms. But do you have access to mental health services? Where are you in the state of Maine? I mean, those services definitely vary all over the state. So getting in touch with that. And that's pretty much what our group had.
Totally. Thank you. Are there any other folks who want to chime in on something you thought of when you thought about the individual variables and experiencing a traumatic event? I thought those were excellent. And there's so many. I just think about my own assumptions and biases when I have someone in front of me who's experienced a particular traumatic event, and the assumptions I make about how it's going to impact them. And I don't know any of those variables, right? Like they do make a huge difference. I really appreciate that. Something we think about also is individual lived experience. You referenced earlier trauma, earlier child abuse, but also thinking about if someone's been a part of a marginalized population, and if their race, their ethnicity, their gender expression, or sexuality has impacted how they live safely in the world or not, how they've experienced traumatic events, whether or not they trust the system that they've been put into. I think individual lived experience when it comes to other sort of oppressions also intersect with our experience of traumatic events. Thanks, group one. All right, group two is going to chat about the event itself, what variables might impact how you experience that event.
I can go for group two.
Please.
So we discussed first the relationship with the perpetrator, how that can affect the event itself, how intimate that is. Trauma is already pretty intimate, but depending on who's perpetrating, it can add another layer to that situation. And then we discussed the location. So where the event occurred, if it was in the home or at work, on the way to work, or maybe somewhere random, but that can also affect how someone perceives a traumatic event, and also how they move forward in the future, having to go to that location, or how that can affect them in the future. And then also their age, so how old they were when they experienced the event. That looks very different from one developmental stage to the next. So when you're younger, you might not know that you were experiencing abuse, and then that takes some time to unfold, or you're older, so that definitely molds how the traumatic event affects the person. And then the last thing we discussed was the response. So from the family, advocates, or law enforcement. So the response, as we know, can really either make or break a situation for someone. If they feel supported, they might be able to go through with, reporting something or facing the abuser, or what have you. So that's kind of what we discussed with just event factors and trauma.
Excellent list. Anyone have anything they want to add to that list?
Gabrielle, as I was I'm sorry, talked over someone. Who was that?
I don't think so. I didn't see anyone unmute unless it was Matthew Wyman, who may or may not have done it on purpose.
All right, I'll continue.
Yeah.
Just hearing you speak, Gabrielle, also reminds me that it's not the facts of the event that impact trauma, but it also can be the perceptions of the event. For example, if someone's robbed and someone's pointing a finger gun under their jacket, but the person being robbed doesn't know that, and they think a real gun is in play, their trauma reaction and their response is going to be based on what they think is happening, not what actually is happening. And I just love how kind of what you were saying, and it reminded me to remind myself and to remember that it's, you know, I could stand back and be like, but there wasn't a gun, you know, your life really wasn't in danger. They weren't really going to hurt you. They just wanted your wallet. But that's just discounting the perception of the event, which is really where the trauma response will be based. So thanks, Gabrielle.
That's really helpful. It's also really helpful because survivors of traumatic events are going to replay that too. And they're going to minimize their own experience and say, why am I reacting this way? It wasn't a gun, right? And so I feel like the importance of understanding trauma is so that we can meet people where we're at, check our own biases, and show up ready to affirm and trust someone in moving forward. But I also think we're there to do a small amount of education and debunking about how traumatic events are experienced. And like being able to say to someone, yes, but you thought your life was in danger. Whether or not that was a real weapon really matters for how someone experiences that event. So I really appreciate that, Kayce. All right, group number 3, we didn't forget about you. Talking about environmental considerations.
This is Mary Hastings, by the way. I don't have a camera that works when I'm at my docking station, so I'll steal a name, but I'm here.
Okay.
We had environmental factors such as time, place, cultural influences. Stephen and Kimberly were in my group, and we kind of talked about specific cases that we are working with right now. So Kimberly, pipe in if I misspeak, but she's working on a case that has the family here in the U.S. as well as family in their home country of Sudan, and you know the perpetrator is not only is threatening people in the home country, which occasionally people do disappear in that country, and this is a real fear to the victim in that case. And she is reluctant to continue going forward and cooperate with prosecution in fear of her family that's, you know, from afar.
Yeah.
And we also talked to, we didn't really talk, we ran out of time once we got figured things out, but we have a large solar project going on in the Franklin County area right now that's bringing a lot of people, a lot of diverse communities to our area. I recently had a domestic violence case with a victim that doesn't speak English. So we have that communication barrier to work around. We're able to find a family, you know, trusted friend for an interpreter for conversations between like myself, the advocate, and the victim. But that trusted person isn't approved by the court system to work with us in the courtroom dynamic. So just factors and barriers of that. She's reluctant to go forward because she's just uncomfortable being in this area with a communication barrier, not having support.
Yeah, those are excellent examples. Thank you so much, Mary. And Kim wanted to mention that women, the value of women in culture is going to impact someone's experience of trauma. And something you bring up, Mary, that I think impacts trauma as well is it started with the event itself, the response, maybe in the moment, how people responded, either bystanders or well-intentioned, concerned others or family and friends, but also in the environment, we have the system that responds. And one of the things we talk about in the world of trauma-informed and healing-centered care with advocates and with our multidisciplinary partners like you all is figuring out ways to minimize re-traumatization or additional trauma by the system. And so, like, is it scarier than the traumatic event of this threat of harm to other people? We don't know, but it's a consideration and something to think about. So super complex, really important. Thanks for those concrete examples. Right. Thank you for brainstorming with us. The next thing we want to do is dive in a little bit more into this definition, into our building a sphere and really comprehensive understanding of trauma. We are going to watch a video by Nadine Burke Harris, and it's 15 minutes. You can settle in, you don't have to talk or answer questions. And she's going to focus even more on the research of trauma, the science of trauma, and then trauma across the lifespan, referencing adverse childhood experiences and how trauma impacts from a traumatic event impacts, who's sitting in front of us at the DA's office, but also other factors of our life across a lifespan. All right, so I'm going to play it from my screen. So if there's any issues with video, just holler, let me know. This should be it. And here, oops, nope, but I didn't do the thing. We've learned I can't actually facilitate and share a screen at the same time. Share sound, open window. There we go. Okay, how does that look? Can I get a thumbs up or a hat? Okay. Try and get
CDC and Kaiser Permanente discovered an exposure that CDC.
Okay, I think it's ready. It doesn't like being on the big screen. 1 second, we'll start her here and see what happens.
'90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA.
Sorry, folks. Everyone should stretch. Take a breath. Kara, will you try playing this?
Yeah,
I
just
sent it to you.
yes, I will. Hold on. Okay, I'm gonna work on sharing my screen.
Thank you so much. Yeah, mine's still loading for some reason. And I would play it small before making it big. It was cranky for me. Oh, we can't hear it. You have to make sure you share your sound as well.
Just a minute.
I'll share it in the chat for all of you too for later, if you want to share or look at it again.
Okay, here we go again.
The lifetime risk of heart disease
Perfect.
and lung
Thank you.
cancer, and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or a packaging chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California. And together, we opened a clinic in Bayview, Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities: access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, Dr. Burke, have you seen this? In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC, and together they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you know, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand better than we ever have before how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior. And that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is wonderful if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal systems, and even the way our DNA is read and transcribed. So for me, this information threw my old training out the window, because when we understand the mechanism of a disease, when we know not only which pathways are disrupted, but how, then as doctors, it is our job to use this science for prevention and treatment. That's what we do. So in San Francisco, we created the Center for Youth Wellness to prevent, screen, and heal the impacts of ACEs and toxic stress. We started simply with routine screening of every one of our kids at their regular physical, because I know that if my patient has an ACE score of 4, she's 2.5 times as likely to develop hepatitis or COPD. She's 4.5 times as likely to become depressed, and she's 12 times as likely to attempt to take her own life as my patient with 0 ACEs. I know that when she's in my exam room. For our patients who do screen positive, we have a multidisciplinary treatment team that works to reduce the dose of adversity and treat symptoms using best practices, including home visits, care coordination, mental health care, nutrition, holistic interventions, and yes, medication when necessary. But we also educate parents about the impact of ACEs and toxic stress the same way you would for covering electrical outlets or lead poisoning. And we tailor the care of our asthmatics and our diabetics in a way that recognizes that they may need more aggressive treatment given the changes to their hormonal and immune systems. So the other thing that happens when you understand this science is that you'll want to shout it from the rooftops, because this isn't just an issue for kids in Bayview. I figured the minute that everybody else heard about this, it would be routine screening, multidisciplinary treatment teams, and it would be a race to the most effective clinical treatment protocols. Yeah, that did not happen. And that was a huge learning for me. What I had thought of as simply best clinical practice, I now understand to be a movement. In the words of Dr. Robert Block, the former president of the American Academy of Pediatrics, adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And for a lot of people, that's a terrifying prospect. The scope and scale of the problem seems so large that it feels overwhelming to think about how we might approach it. But for me, that's actually where the hope lies. Because when we have the right framework, when we recognize this to be a public health crisis, then we can begin to use the right toolkit to come up with solutions. From tobacco to lead poisoning to HIV/AIDS, the United States actually has quite a strong track record with addressing public health problems. But replicating those successes with ACEs and toxic stress is going to take determination and commitment. And when I look at what our nation's response has been so far, I wonder, why haven't we taken this more seriously? You know, at first, I thought that we marginalized the issue because it doesn't apply to us, right? That's an issue for those kids in those neighborhoods, which is weird because the data doesn't bear that out. The original ACEs study was done in a population that was 70% Caucasian, 70% college educated. But then, the more I talk to folks, I'm beginning to think that maybe I had it completely backwards. If I were to ask, how many people in this room grew up with a family member who suffered from mental illness? I bet a few hands would go up. And then if I were to ask how many folks had a parent who maybe drank too much, or who really believed that if you spare the rod, you spoil the child, I bet a few more hands would go up. Even in this room, this is an issue that touches many of us. And I'm beginning to believe that we marginalize the issue because it does apply to us. Maybe it's easier to see in other zip codes because we don't want to look at it. We'd rather be sick. Fortunately, scientific advances and, frankly, economic realities make that option less viable every day. The science is clear. Early adversity dramatically affects health across the lifetime. Today, we are beginning to understand how to interrupt the progression from early adversity to disease and early death. And 30 years from now, the child who has a high ACE score and whose behavioral symptoms go unrecognized, whose asthma management is not connected, and who goes on to develop high blood pressure and early heart disease or cancer will be just as anomalous as a 6-month mortality from HIV/AIDS. People will look at that situation and say, what the heck happened there? This is treatable. This is beatable. The single most important thing that we need today is the courage to look this problem in the face and say, this is real and this is all of us. I believe that we are the movement. Thank you.
All right, thank you. So a helpful reminder, this is a foundational training. That is some of our favorite ways in the sexual assault, anti-sexual assault world to think about and learn about how the brain reacts to trauma and how it impacts us. But reflecting on her words and the concept of ACEs, how does this influence how you think about your work, the work you do day to day, and how you think about trauma and the people you're working with? What reflections do you have? Is there anything she said that stood out or resonated with you? Or like, oh no, how are we going to fix this? Why are you telling me? This is just making it worse. What do you think?
I mean, for me, not necessarily in my current position because I've only been here like a month, but but before this, I worked for a teen center and we did a training on ACE scores, so I'm like very familiar with it. And her line about we'd rather be sick really hit because I worked with at-risk teens, and it was oftentimes I would see like the people in these teens' lives, like the adults, the parents, the supervisors, the guardians, just didn't want to acknowledge that trauma had happened or trauma was happening, or maybe they'd had a hand in this trauma, maybe accidentally, because it's difficult to nail down. And I think that's true for kind of a lot of systems, like kind of overarchingly. It's trauma is really difficult to detangle. And I think pretty much everybody has been through some sort of trauma. So that's millions of people's worth of trauma to kind of stare down at.
Yeah, it's a big ask. It feels overwhelming to me. Yeah, thank you. And for folks who already sort of hold the understanding of trauma and ACEs, how you use it or think about it, I would be curious. Any other things that resonated or didn't resonate?
I think that one of the things that stands out for me, Katie, and I think this is, I don't know, maybe the third or fourth time I've seen this TED Talk, is just really thinking about those maladaptive behaviors. And, you know, like you were talking about earlier, this is also a process of constantly examining our biases and our assumptions and the kind of stereotypes and all of that I bring with me. And it's such a good grounding reminder for me to not judge people's behaviors, because they may in fact be those maladaptive behaviors that she was talking about. And it can be really easy to, I think, get caught up in the judgment of those. And the reality is that I have no idea usually what has happened to an individual and why they're acting in the way they're acting or doing or using the things that they're using or doing. And then for the people I do have in my life who exhibit maladaptive behaviors, like in my personal life, it helps me to have a bit more empathy. And understandably, maladaptive behaviors can also lead to abuse of oneself and others. So we certainly have to make sure that we're recognizing that. But I guess it helps me to have a little bit more empathy and reminds me to have that empathy, because I don't know what's behind of behavior.
Thank you. And then Kim is identifying, this is totally what I think of too, Kim. I think we've all dealt with child victims whose parents have also been victims of trauma in their childhood. The parents' trauma definitely impacts how they deal with their child's own trauma. 100%. That really resonates. The other thing I think about is, because I'm not doing direct service anymore, my role is to support people doing direct service. I think about you all. I think about your own supports you're getting around the work you hear, what you're witness to, and how hard it is. And I also think about, it's not as much in this video, but it does exist. You know, some of the work around countering ACEs is medical interventions, clinical, but a lot of the other work is also around just increasing the number of healthy and trustworthy people in a young person's life. Like that is a counteraction to ACEs. And so I think of the same as someone navigates through a criminal justice system, has experienced a traumatic event, has all of these variables that impact them differently, like how they experience that event, plus whatever trauma came before. And that coming into a system where they have someone who's reliable, who they can trust, who affirms their experience and hears them, in and of itself can be healing, can be at minimum not re-traumatizing. And that's actually, I mean, that awareness and that change in how we provide advocacy, how victim witness advocates talk to and listen to survivors, this is newer information. This foundational, what trauma-informed is and what trauma-informed care looks like, is still newer in our conversation. So I do think there is a lot of opportunity and power within your own role to be part of that healing process, part of things that counteract traumatic experiences. I offer that as an intro to your slide, Kayce.
I was just gonna say, Katie, that's just the perfect segue to the rest of our presentation. So let me screen share. All right, so we have done this. Here we are. All right, so we are going to kind of move into defining trauma-informed care. We've talked about trauma. We've talked about some of the impacts of trauma. We've had an opportunity, you've had an opportunity to discuss and share factors that influence trauma and trauma response. So with that foundation, we'll move on to define trauma-informed care. And again, I'll read a brief excerpt from our foundation's curriculum. Trauma influences how people approach and respond to systems and services, making it essential that all of us, sexual assault advocates, domestic violence advocates, victim witness advocates, all of us recognize the expressions of trauma and acknowledge the role that it plays in people's lives. Trauma-informed care involves each system the survivor comes into contact with. So each one of those systems and services providing support and providing services without causing re-traumatization. Trauma-informed care is a philosophy and a skill set. And I love thinking about trauma-informed care as a skill set because it reminds me that I'm in a very ongoing fashion building my skills. I don't have to be doing it perfectly right now. This is something that I'm learning every day and growing in every day. It also reminds me that we get to learn this and practice this together. And together we get to build our capacity to provide this type of care to people. And I just find that really, really amazing. Trauma-informed care provides a framework for understanding the impact of trauma on survivors, on communities, and on those who serve them. So just like Katie was just saying, trauma-informed care involves all of you and all of us as well. We're going to do a couple of activities here. So these are the real tenets or the real critical aspects of trauma-informed care. And I believe the definitions of these are going to be shared in the chat. Is that correct, Katie?
So the email that Kara sent ahead of time has a handout that is called Building Cultures of Care. If you got that in an email as an attachment, you can open it now. Also, Kara just put it in the chat, that Google Drive, that form, it's there. So we'd love for you to open it and have it available, because we're going to read it now and reference it in breakout work.
Great, thank you so much, Katie. And so we are going to go through and read these 6 critical aspects of trauma-informed care, but I would love to hear other people's voices. So if you could open that document, and if you'd be willing, we'd love to have a volunteer to read the first tenet, which is safety. Is anyone able and willing to do that?
And the link should be set up now so that anyone, you can just click it and the Google Doc will pop up.
Are we just reading the just like the text underneath?
Yeah, do you want to read safety and the text?
Yeah.
Awesome, thank you.
You're welcome. I just didn't want to like read a paragraph and you're like, oh, that's the wrong paragraph. Okay, so safety. Throughout the organization, the staff and the people they serve, whether children or adults, feel physically and psychologically safe. The physical setting is safe and interpersonal interactions promote a sense of safety. Understanding safety as defined by those served is a high priority.
Awesome, thank you so much, Matthew. So that is our first tenet of trauma-informed care, safety. I would love for someone who might be willing to read the next one, which is cultural relevance. Anyone be willing to read cultural relevance and the definition underneath?
I will do so.
Thank you.
I gotta go to bring it up. Cultural relevance. The organization actively values and works to connect survivors with culturally relevant support, including for mainstream programs, referrals to culturally specific organizations and services. The organization also incorporates policies, protocols, and processes that are responsive to the racial, ethnic, and cultural needs of the survivors served, and recognizes and addresses historical trauma. Similarly, the organization's internal policies, protocols, and processes for staff reflect cultural awareness and a commitment to equity.
Great, thank you so much. And as you can imagine, I would love it if someone now could read trustworthiness. Any takers for trustworthiness?
I will read that one. Trustworthiness. Decisions are transparent and people and relationships are prioritized. Building and maintaining trust with survivors, staff, and others involved in the organization is core to the organization's work.
Thank you so very much. How about choice?
I don't mind. I'll read choice. Organizations understand power differentials and the ways in which survivors have historically had voice and choice taken away from them. Survivors are supported in the decisions they make and what they identify as needed to help them heal. Staff are also supported to make decisions in how they do their work.
Thank you. So we just have 2 more. Collaboration. Anyone willing to read collaboration?
I can read collaboration. Collaboration. Importance is placed on leveling power differences to meaningfully share power and decision making, both in advocacy work with survivors and across all levels of an organization.
Thank you, Katie. We just have one more, empowerment.
I'll read it. Advocacy staff and other potential service providers are viewed as potential helpers along a survivor's healing journey, but not in control of healing. Survivors are encouraged to practice awareness of their strengths and set their own goals for what feels empowering as they heal.
Thank you so much, everyone. And I also want to honor that there may have been people who wanted to participate, but maybe you were unable to bring up the handout and the definitions. But thank you. It's just really wonderful to hear other voices and get people talking, even if it's reading from a script. I just really appreciate it. So at this point, we're going to move into an activity. And then after this break activity, you are going to have the opportunity to come up with some examples of what you currently do or what you'd like to be doing, that practices that fit into these core components of trauma-informed care. But before you do that, and to give you a little bit of a reference point and maybe help you brainstorm and think a little bit, I'm going to read some example cards. So I'll read 6 example cards, and certainly the examples may fit into more than one of our categories here or definitions. But if you can try to fit it into one, what I tried to do, hopefully I was successful, we'll see. I tried to pick 6, one for each. So, all right, so let me read. And then people can, please feel free to unmute yourself. I'd love to hear your voice, or you can certainly also, if you're more comfortable, share your response in the chat.
It makes me feel like Zoom should create a buzzer system for like a quick round. I mean, not that I want people to be thoughtful, but also I kind of wish there was a way for you all to like buzz in. But anyway.
I got it first.
Yeah.
And then if that happened, then I would really want to have prizes for people. So
for sure. Anyway, for another day.
Here's the first example. Service providers are consistent in how they respond and follow through with survivors. Where do you think that one might fit? Service providers are consistent in how they respond and follow through with survivors.
Katrina says trustworthiness in the chat.
Awesome. I would agree with that. Thank you. How about this one? Survivors and staff are informed of grievance procedures should they have an issue and would like to seek remedy. So informed of grievance procedures. Read it one more time, see if you have any thoughts. Survivors and staff are informed of grievance procedures should they have an issue and like to seek remedy.
Kim says collaboration.
Great, thank you. And I might also, is there another response?
Holly says safety. Interesting, because I was thinking empowerment. So.
And yeah, I was thinking empowerment as well. Because, you know, here in this example, we're empowering staff, you all, us all, and we're also empowering the people we serve, that if they don't like something that's going on, if they have a grievance, then they have a process for that. And I feel like that is incredibly empowering. I also feel that that's incredibly safe. Mm-hmm. and it's imploring choice. So again, many of these can go into multiple tenants. All right, how about the next one? Service providers listen to survivors and families to understand what makes them feel safe or unsafe.
Empowerment, trustworthiness, and safety all came in at the same time.
Awesome, yes. And if you're keeping score of my 6, that one was kind of for the safety. But absolutely, it's so multi-layered. Services are available in multiple languages. Where would that example fit?
Cultural relevance from multiple people.
Great, thank you.
Also safety, says Kara.
Yeah. And choice, right? If people did speak multiple languages, but they wanted to speak in their native language, choice, definitely. How about advocacy programs have close partnerships with culturally specific programs and partners? So programs and services have close partnerships with culturally specific programs and partners.
Collaboration, says Gabrielle and Holly.
Great, thank you. And the last one, survivors are never pushed to pursue one option or another. They are provided with information about options and encouraged regardless of what they decide.
Mary and Gabrielle and Holly all say choice.
Great, thank you so much for engaging with that activity. And now I think Katie's going to lead you into another activity where you'll get to share your own examples.
Great. So I need you to either have that handout up or write down these 6 categories while I explain what we're doing. We're going to put you into breakout rooms again for about 10 minutes, 7 to 10 minutes, in pairs and triads. And while you're in that pair or trio, we want you to think about your own role, your own office, your own department, and what things are you currently doing or do you want to do that practice trauma-informed care, 1 for each category. So the 3 of you together come up with 1 example for safety. You're welcome to do more than 1. 1 example for cultural relevance, 1 example for trustworthiness, and then 1 will come back and share. And we'll also, as you're thinking about it, you can think about the places that feel really where it feels hard to do trauma-informed care, to do this very concrete stuff. So again, I want you to write down these 6 categories, come up with, there's a squirrel in my yard, I apologize. Hey, no, not happening. And think of 1 for each and think very concretely. Think about your building, think about your office, think about where you sit, what you do day, the forms you give people, the hallways people wait in. Like, you can think very concretely. You can also think really big picture. Does that make sense? Current or hopeful trauma-informed practices, and we'll come back 1 for each category, and then we'll come back and share. We'll give you about, probably, I feel like need 7 to 10 minutes. So if you have any questions, you can grab us. There's a way to ask for help. Also, if you're done, you can come back. You can leave your room, and that will indicate that folks are wrapping up, and that's helpful for us too. You're welcome to wait around, but you can also come back. Sound good? Okay, so we'll see you in about 7 to 10 minutes. in the void?
I did. I found my way and we had a great breakout session.
Oh,
Did you end up, just out of curiosity, did you end up seeing something that took you there, or you just were swift, like,
No,
take
I
away?
hit join and I was going to join room 3 and then it switched to room 4, which was fine by me.
We
but-
did that because there was only one person in each room, so I'm glad it
Oh,
worked.
oh, okay.
All right, welcome back. Thank you. Okay, so we have a bit of time left with each other. We'd love an example from each that will rely on this kind of unmuting and chiming in or chatting. So the first question I have is, how was that? Was that difficult or relatively easy to come up with an examples? Raise your hand if it was difficult, or give a reaction. Or did you have some examples ready to go? Some nods? Okay, good enough. I'll take it. All right. Who would like to share an example of what you currently do or could imagine doing in your capacity to practice safety, trauma-informed care, and the role of safety?
Well, I guess we can start if you
Yeah.
want. Matthew and I were in a group. So you want me to just, we didn't make it all the way through. Because we talked a lot of, we come from different types of offices. So we talked a lot about that. So
how about you share your first two? How about you share safety and cultural relevance and what you think?
Okay. So with cultural relevance, we both talked about, as far as what we're doing now, using interpreters in the language line,
Yep.
Which is the most available to us. I know that here in the DA's office, I wish that we had the forms that we use in a lot more languages, because we don't. We only have our letters and our forms go out in English, and that's it. So I would really like to see something done with that. And Matthew agreed with that as well, where he's only been in his job for 3 weeks. He's kind of been working remotely. So I don't know that he has had an opportunity to see a lot of what they use for folks. For safety, Matthew talked about the where they are currently located. They have a lot of space, because I had talked about our building, and my wish list is that we had more entrances to be able to bring people in, that if I have a victim coming in, they don't necessarily have to go through the same door, security, and as the alleged perpetrator potentially.
Yeah.
So I wish I had another way to be able to bring them into the building and more places to put them during a trial or a hearing, anything that might be going on, so that they don't have to see that person until it's absolutely necessary.
Yep.
One of the things that we thought was good that came out of the pandemic, in regards to safety and alleviating some of those issues for victims, was Zoom. You know, being able to have a meeting for them in their living room, not having to worry about transportation and childcare, and are they watching me leave my apartment to go someplace? Those types of things.
Yeah.
Yeah.
Awesome. Thank you.
Sure.
I was also thinking about safety. I was picturing your building. I was picturing the metal detectors and entering the building. And as an advocate, that always made me feel safer, but that may not be everyone's experience. But I do think of the number of people you have staffed designed to keep everyone safe too.
Right. That's true. I just worry about them being in line with the person.
I do too. Yeah. Totally. All right. Thank you, Kim and Matthew. Would another pair like to share the next two examples of trustworthiness and choice?
I can share.
Please do. Thank you.
So for trustworthiness, we discussed how we need to be sensitive to their perspective of the criminal justice system as we're working through it. So just kind of respecting whatever that may look like, and not trying to force, any sort of narrative on them that they need to go forward doing something, and that kind of ties back in choice. So I think that trustworthiness and choice kind of intermingle there, where it's like giving them choices and allowing them to make those decisions, kind of helps build that trustworthiness.
Great, thank you. The other thing I think about for trustworthiness that I've observed over the years is the power of being somewhere when you said you're going to be there. I mean, it seems really simple, but like if I say I'm going to call you back, actually calling you back, especially when people come into a system where they might be interfacing with the advocate, the counselor, the boss, like so many, to be that like constant, reliable human, I think goes a long way to building trust. All right. Who wants to share some concrete examples of the last two, collaboration and empowerment? You can type too.
I can share.
Please do.
For collaboration, I just noted all the agencies that we work with, Safe Voices, SAPers, our local law enforcement agencies, that our office may not be able to provide a resource that they need, but Safe Voices may, or SAPers may, and we're really good at connecting them with those other people. If they've already been referred to Safe Voices by the law enforcement agency, but they are either having trouble getting through or the advocates reaching out to them and they just haven't connected, I can, fire off an email or a follow-up phone call and say, this person really does want to work with you, or this person's trying to reach you, maybe if you want to follow up with them. So we are all on the same team, and I do think we all have a common goal. Sometimes we, have to help each other out.
Yeah, I think that follow-up is really key. It's super, super valuable practice. And similar to the timeliness, it feels like in all of the things you're juggling, all the things you're doing, it feels small, but I think it's a really valuable and important practice.
And it can be something perfectly simple. The Safe Voices advocate may have been in court all day. So this victim is like, oh, they won't call me back. Well, they just haven't been available, but I'll let them know that I've been in touch with you and that you're trying to get in touch with them. And this is what your needs are, or what your concerns are. And they do the same for me. So yeah, we're pretty united on that front, which is really, really great. That was my example for collaboration. Empowerment is probably one of the most important things to me and the people that I work with. It's not very often that we have an outcome that everybody's satisfied with.
Yep.
Either it be law enforcement or the victim or the defendant or whatever. Yep. I do try to make sure they have a choice and the opportunity to either be at the sentencing or voice their thoughts either through myself or a victim impact statement, or be present if they want to. But I also tell them, if going to court's going to stress you out, if it's a hardship with childcare or missing work, if it's not going to bring you peace and closure, then it's okay to not do that. It doesn't mean that you care any less. It doesn't mean that this didn't happen to you. And a lot of times I find these people just haven't had anyone really listen and say, I'm sorry for what you've been through.
Yeah.
And when you give them that time and listen to them, that's what they need. That gives them the power back.
Yeah, thank you so much, Mary. I just really, really appreciate you saying that. And absolutely, it's the reality that, and still it boggles my mind when I'm either sitting across from someone, on the phone with someone, or maybe even been on Zoom with someone, and I will just say something as simple as, "You're doing the very best you can given the situation, and no one can ask more of you." And watching, like, just watching that expression, and sometimes that's an opportunity that people will let go and just need to cry, because no one has just said, "You're doing the best you can, and that's okay, and I hear you and I believe you," and just all of those really core messages of validation and non-judgment. They're so powerful, and they go a really, really long way, regardless of what service we're providing or what role we're in. And so, yeah, thanks so much, Mary.
Yeah, thank you. That was perfect.
I absolutely agree. And I'm sometimes shocked by just simply saying, "I'm sorry that happened to you," or you don't deserve this to happen to you. People are blown away by that. Like they've never heard it before. And kind of makes you stop and think.
Yeah, thank you. And you acknowledged something really important, Mary, which is that you are working within a system where sometimes survivors who are victim witnesses may not have choice in testifying in what's going to happen with a case. And there are also places like that you don't have the power within your role to change policies or protocols. And we don't have time right now to sort of unpack what it means to try to apply a trauma-informed practice in places where you're limited. But I know by gathering together, by connecting with each other and having Kara, you'll have more opportunities to look at that, to unpack that. There's going to be a follow-up training in the fall around communication and keep this thread and this theme of trauma-informed care and trauma-informed practice. So we're also here for any more training and conversation about it, but it's tricky. And I've watched really amazing victim witness advocates like navigate, how do I have this practice in a system that may inherently not offer choice, that sort of thing. So I just wanted to acknowledge that this is hardly simple and that there will be more conversations to come. We have one last slide, one last concept we wanted to share with you before we left. And that I also think Mary teed up well for us around language. So when we think about trauma-informed and healing-centered care, we're thinking about acknowledging that everyone carries with them trauma. It impacts them differently, and that we have to meet this whole, holistic, imperfect person where they're at. And how we talk about their experiences and how we talk about them as humans, I think can either increase our ability to do that, to meet someone holistically, to check our biases, or it can minimize that. It can make it easier for us to sort of like, whether it's for the sake of efficiency or clarity or just stress and time or trauma on our own selves, our language can also sort of boil someone down to just the trauma they experienced or dehumanize them in a little bit. So there's a lot of great information and articles out there on person first language. There's also some awesome disability justice folks talking about person first language and whether or not they want it used. So it's not a set in stone. It's an ongoing conversation, but this is a moment for you to pause and consider your language and how you talk to each other and your DAs and your sexual assault advocates. And really trying to apply this language to the people you're working with. So these are the examples of person first language. He was hospitalized for medical care instead of he got 302'd. A person who uses a wheelchair instead of disabled. And then the next slide, she chose not to do that instead of she was non-cooperative. They're trying to decide what's best for them instead of they're unwilling to make a decision. So this, I also see these examples specifically couch the language in those 6 tenets. What is happening here and how And what does that have to do with the trauma-informed care we provide? And how do I affirm this person for all that they need and where they're at? So again, this is not prescriptive or final, but just a consideration as you move forward and think about your own trauma-informed practice. Any thoughts on that? Any reflections or anything like? Stand out? I don't know if people offer feedback 4 minutes before training is over. They're like, no, shh, don't. Okay, just food for thought. Kara also has the PDF slides if you're interested and want to reference that again. So something else to take with you, trauma-informed care is only as accessible as the support we provide to the folks doing care work. So we hope that in addition to information, that today we provided a couple hours of care and support for you in your role. Super excited you're here. Thrilled for the work that Kara is doing. And we're available here and we'll hang out for a few minutes if anyone has any questions. And just really appreciate those of you willing to jump in and share and read and be with us here this morning. Thank you so much.
Yeah, thank you so much, Katie and Kayce, for your time today. Thank you everyone who came to participate today, because one of the things I love about the trainings that Mikasa puts on is it's really about gathering the wisdom in the room, and there's clearly a lot of wisdom here. It's really wonderful.
Have a great day, everyone.
Yeah, enjoy your lunch.
Great.